Good morning. This is the January 26, 2022, and we are here to hear our student, our grad student, Caroline Gomes. She is today presenting his project for the title of PhD in Science. Her project is Inspiratory Muscle Capacity with Abdominal Support, Prospective Observational Study in Critically Ill Patients. I apologize for this delay. We had a technical problem here, and today we have a lot of students doing this exactly same activity. So our technical support is kind of busy, but now we are ready to start. I will present all of you later in the discussion part. And then now we will invite the grad student, Caroline Gomes for her presentation. So please, Carol.
Thanks, Professor Clarice. Good morning. I would like to thank you all for being here with me today to present my PhD presentation, my PhD research. My name is Caroline Gomes, and I'm going to present the research entitled Inspiratory Muscle Capacity with Abdominal Support, an observational study in critically ill patients. And Professor Clarice was my mentor to conduct this project. This project is part of a bigger project entitled Respiração diafragmática modificada, impacto na função respiratória. And it was approved by the Ethics Committee from the Hospital das Clínicas da Faculdade de Medicina da Universidade de São Paulo. Our main purpose was to investigate the inspiratory muscles capacity with abdominal support. However, during the patient's assessment, another research question caught our attention. Is there any relationship between diaphragm excursion, inspiratory muscle strength, and lung aeration in critically ill patients? So we performed the secondary analysis to answer the research question 2. This research has also allowed us to present 3 posters in important scientific congress, 2 in 2018 and 1 in 2020. And we also have produced 1 manuscript for each research question developed. Introduction. Breathing is a complex movement that involves many muscles acting together to maintain an adequate respiratory function. The diaphragm is the most important respiratory muscle. However, it depends on a synergic contraction with the intercostal and the abdominal wall muscles to generate an adequate transdiaphragmatic pressure. The abdominal wall muscles have been largely known as inspiratory muscles. Their primary action is to pull the abdominal wall inward and increase intra-abdominal pressure. When they contract, cranial diaphragm displacement is produced, which leads to a rise in the pleural pressure, and if the airway is open, it can decrease the lung volumes. This mechanism allows the abdominal wall muscles to play a major role in activities such as coughing and speaking. By forcing the diaphragm cranially, the rise in the intra-abdominal pressure produced by the abdominal muscles increase the diaphragm zone of opposition. This mechanism puts the diaphragm in an optimal length for tension generation, which can improve his capacity to generate force. Thus, despite it being recognized as inspiratory muscles, the abdominal wall can also be recruited to improve inspiratory muscles capacity and the diaphragm efficiency of contraction. Respiratory muscles dysfunction is a common complication related to critical illness, and diaphragm excursion diaphragm weakness has been largely investigated, and it was related to poor prognosis. The inspiratory muscles weakness was also investigated in previous research. However, the understanding of the abdominal wall muscles function during inspiration is still largely unknown, especially in critically ill patients. Therefore, we conducted this research to investigate the inspiratory muscles capacity in critically ill patients with and without abdominal support. Additionally, secondary aims were also developed to answer the research question 2, as follows: to investigate the relationship between lung aeration, diaphragm excursion, and maximum inspiratory pressure, and to investigate if the diaphragm motion dysfunction could be predicted from the patient's clinical characteristics. Materials and methods. Adult patients with an ICU length of stay higher or equal to days, who were breathing spontaneously and with a Glasgow Coma scale higher or equal to 14 were included. Those patients with neurological disease, thoracic traumas, ascites, hemodynamic instability, or pain at the moment of the assessments were not included. Demographic and clinical data were extracted from the medical records, and all the patients were assessed by ultrasound, manovacometry, spirometry in a supine position with a 45 degrees of turn flexion. The patients were assessed during 3 different respiratory patterns. Breathing pattern 1, during tidal breathing. Breathing pattern 2, breathing without abdominal support, and breathing pattern 3, breathing with abdominal support. For the breathing pattern 1, patients were instructed to close their eyes and breathe quietly to allow the assessments during tidal breathing. Additionally, to allow the analysis to answer the research question 2, maximum inspiratory maneuvers were also assessed during the tidal breathing pattern. For breathing pattern 2, the patients were instructed to perform a maximum inspiratory effort, emphasizing an outward displacement of the abdominal wall. For this breathing pattern, a belt was positioned around the abdominal circumference without any tension applied. For the breathing pattern 3, the patients received the same instruction to perform a maximum inspiratory effort, emphasizing an abdominal wall outward displacement during inspiration. However, during this breathing pattern, the belt embracing the abdominal wall has a tension applied of 10 millimeters of mercury. This tension was applied to simulate the tonic activity of the abdominal wall muscles during breathing, producing a slight increase in intra-abdominal pressure. And to standardize and control the tension applied, a pressure biofeedback unit was used. To avoid learning bias, the assessment sequence after the breathing pattern 1 assessment was randomly distributed so that part of the patients started the assessments with the breathing pattern 2, and part of the patients started their assessment with the breathing pattern 3. A second research was responsible for placing the belt in an adequate position and for setting the pressure as 0 or 10 millimeters of mercury accordingly. For answer research question 1, lung ultrasound score, diaphragm excursion during tidal breathing, and diaphragm thickening fraction were assessed during the breathing pattern 2. And during the breathing patterns 3, 2, and 3, vital capacity, maximum inspiratory pressure, diaphragm excursion during a deep breathing, and diaphragm thickening fraction were also collected. To answer the research question 2, diaphragm excursion during a maximum inspiratory effort and maximum inspiratory pressure were also collected during the breathing pattern 1 assessments. As the diaphragm impairment can be caused by many conditions related to critical illness, we created a diaphragm dysfunction risk score to predict the risk for diaphragm dysfunction. The diaphragm dysfunction risk score was calculated as the sum of points resulting from each risk factor presented by the patient. And risk factors such as age, sepsis, abdominal surgery, immunosuppression, disease severity, mechanical ventilation, and nutritional status were considered. The ultrasound assessments were performed by the same trained and blind researcher. For assessing lung ultrasound score, we used the methodology described by Summer and co-workers in 2012. And for the LUS assessment, the chest wall was divided in 12 chest regions, 6 each side as demonstrated in the picture. Each chest region was assessed and scored according to the worst ultrasound characteristic, which can vary from 0, which means normal lung aeration, to 3, which means total loss of lung aeration. The lung ultrasound score can range from 0 to 36, and higher values are related to higher lung aeration rates. And in addition to the LUS, a lung ultrasound score related to the sum of the 4 lower chest regions, represented by the numbers 4 and 6, was calculated separately and used to characterize the aeration of the dependent lung regions, considering a patient in a semi-recumbent position. Diaphragm excursion was assessed using a convex transducer placed in the right mid-clavicular line at the subcostal area with a cranial inclination. First, the diaphragm dome was visualized in B-mode ultrasound, and then it was measured in M-mode ultrasound as the distance between the 2 distal edges of the hyperechoic line produced by the diaphragm. As established by researchers and co-workers in 2009, diaphragm dysfunction during quiet breathing was defined as a diaphragm excursion less than 9 millimeters for women and less than 10 millimeters for men, and during deep breathing as less than 36 millimeters for women and less than 47 millimeters for men. Diaphragm thickening fraction was added later to the study protocol, and only 12 patients were assessed with this methodology. And to assess diaphragm thickening fraction, a linear transducer was used and positioned at the diaphragm zone of apposition. The M-mode ultrasound was used to measure the diaphragm thickness during inspiration and the diaphragm thickness during expiration. And the increment in the diaphragm thickness during inspiration relative to the end inspiratory thickness was calculated in percentage to represent the diaphragm thickening fraction. Maximum inspiratory pressure was assessed using a digital manovacometer attached to a face mask. For this assessment, the patients were instructed to perform a maximal inspiratory effort from residual volume and a decreased inspiratory muscle strength was defined as a maximum inspiratory pressure under 60 for women and under 80 for men. A digital spirometer was used to assess vital capacity. And for the assessment, the patients were instructed to breathe slowly in tidal volume and then to perform a maximal inspiration to residual volume, followed by a maximal expiration. At least 3 measures were done for each outcome assessed, and the highest value was used for the statistical analysis. All the analyses were done with the SPSS software, version 25 for Windows, and continual variables were expressed as mean and standard deviation, or median and 25 to 75% interquartile range. Categorical data was represented as absolute and relative frequencies, and all the statistical tests were two-sided, and statistical significance was acquired with a p-value under 0.05. To answer research question 1, vital capacity and maximum inspiratory pressure during the breathing patterns 2 and 3 was compared to using Wilcoxon-matched pair sign drug test or paired sample t-test. A one-way repeated measures analysis of variance, ANOVA test, was used to compare diaphragm excursion and diaphragm thickening fraction within the 3 different breathing patterns. The sample size were estimated and calculated based on a pilot study as 30 patients. For answer research question 2, a sperm product moment correlation test was used to assess the relationship between lung ultrasound score, maximum inspiratory pressure, and diaphragm excursion. A multiple linear regression was used to perform a multivariate analysis considering less and less dependent as dependent variables. The chi-square test for proportions or Mann-Whitney rank test was used to compare the patients with and without diaphragm dysfunction during deep breathing. To evaluate the ability of the diaphragm dysfunction risk score for predicting diaphragm motion dysfunction, a ROC curve, a receiver operating characteristic curve analysis was used, and the area under the curve with a 95% confidence interval was used to indicate the discriminatory power of the score system. Results and discussion. Research question 1. Can abdominal support influence the inspiratory muscles capacity in critically ill patients? 50 patients met inclusion criteria, and among them, 20 were not included, so that 30 patients were included and assessed during the study period. The assessment sequence after the breathing pattern 1 assessments were randomized so that 50 patients performed the breathing pattern 2 before the breathing pattern 3, and 50 patients started the assessments during the breathing pattern 3. Table 1 presents the patient's clinical characteristics, and the mean age was 55 years. Most part of patients were male, and it's important to highlight that most patients had a surgical diagnosis during their ICU admission, and all the patients presented some degree of lung aeration loss evidenced by the lung ultrasound assessment. Table 2 presents the inspiratory muscles capacity during breathing patterns 1, 2, and 3, and comparison between the paired measures. Our results demonstrated that maximum inspiratory pressure was higher during the breathing pattern with abdominal support. Apparently, when an abdominal support is applied, there is an increase in intra-abdominal pressure, which puts the diaphragm in an optimal length for tension generation, allowing it to exert greater force at their lower ribs attachments. This could explain why maximum inspiratory pressure was higher during the breathing pattern with abdominal support. In addition to the increased maximum inspiratory pressure, diaphragm excursion and diaphragm thickening fracture were also higher during the breathing pattern with abdominal support. In accordance, which can show us that the diaphragm has a major contribution to inspiratory muscle strength. And in accordance with our results, previous research in tetraplegic patients showed that an abdominal support can have a facilitatory effect on the lower rib cage extension and could also increase maximum inspiratory pressure. We have also observed a slight increase in vital capacity during the breathing pattern with abdominal support. However, it was not statistically significant, and this could be explained by the nonlinear relationship between vital capacity and respiratory muscle strength. Interestingly, we observed a progressive improvement in the diaphragm excursion from the breathing patterns 1, 2 to 3. Indifferently, diaphragm thickening fraction remained similar during the breathing patterns 1 and 2 and increased only during the breathing pattern 3. We think that this difference could be explained by the different recruitment patterns of the coastal and crural diaphragm portions. According to Detroit and co-worker, the isolated activation of the coastal portion of the diaphragm produces a significant increase in the lower rib cage expansion. And differently, the isolated activation of the crural portion of the diaphragm increases the abdominal and the diaphragm motion without an increase in the lower rib cage expansion. As the diaphragm thickening fraction is assessed at the zone of opposition, it reflects mostly the length changes of the coastal muscular fibers of the diaphragm. And consequently, when an outward displacement of the abdominal wall is emphasized without abdominal support, as during the breathing pattern 2, little contraction is elicited from the coastal portion of the diaphragm, which could justify our findings. Differently, when an abdominal support is applied, the increase in intra-abdominal pressure stabilizes the central tendon so that it allows an efficient contraction from the costal muscular fibers of the diaphragm. This explains why it was only observed an increase in the diaphragm thickening fraction during the breathing pattern 3 with abdominal support. Both pleural and costal portions of the diaphragm are involved in the central tendon caudal displacement, which can justify the progressive increase observed in the diaphragm excursion within the 3 different breathing patterns. Research question 2. Is there any relationship between diaphragm excursion, respiratory muscle strength, and lung aeration? Within the 30 patients included, 24 had maximum respiratory pressure and deep breathing diaphragm excursion, also assessed during the diaphragm breathing pattern 1. This allowed the correlation analysis, and as shown in the table 2, diaphragm dysfunction during deep breathing was present in 11 patients. Lung ultrasound score dependent presented values very close, indicating that lung aeration loss was predominantly in the lung-dependent regions. And diaphragm dysfunction risk score was also higher in those patients with diaphragm motion dysfunction during a deep breathing. Table 4 presents the correlations between lung ultrasound score of dependent lung regions, diaphragmatic excursion, and maximum respiratory pressure. A statistically significant correlation was found between deep breathing diaphragm excursion and lung ultrasound score, and a tight correlation was found between diaphragm excursion and less dependent, which suggests that diaphragm dysfunction impacted mostly the aeration patterns of dependent lung regions. MIP, maximum respiratory pressure, did not present correlations with diaphragm excursion. However, it presented a weak correlation with less and less dependent. Our results demonstrate the close relationship between the lung aeration loss and diaphragm dysfunction. This picture illustrates the correlation analysis between the diaphragm excursion during quiet breathing and deep breathing with both less and less dependent. No correlation was evidenced between quiet breathing diaphragm excursion and less dependent. However, diaphragm excursion during a maximum respiratory effort presents a strong correlation with less and less dependent. In addition, the multiple regression analysis showed that maximum respiratory pressure and diaphragm excursion together can explain 37% of less variance and 57% of less dependent variance. And diaphragm excursion has a major contribution and contributed individually for less and less dependent variance. These results reinforce that although breathing integrates many muscles, the diaphragm movement seems to play a major role to maintain the lung aeration, especially at the lung-dependent regions. Some authors reported that diaphragm excursion could be a predictor of change in pulmonary function, especially after abdominal surgery. Another study also found a decreased diaphragm motion associated with a decreased lung compliance in patients who underwent a major laparoscopic pelvic surgery. All this evidence added to our results indicates that the diaphragm motion impairment, especially in lung-dependent regions, the diaphragm motion impairment was strongly associated with lung aeration loss, especially in the lung-dependent regions. The rock curve analysis demonstrated that a diaphragm dysfunction risk score higher or equal to could predict the diaphragm dysfunction with a sensitivity of 81% and a specificity of 61%. There is a well-established relationship between critical illness and respiratory muscle weakness. And besides mechanical ventilation, there are many other facts and risk factors related to critical illness that can contribute to diaphragm dysfunction, as sepsis, abdominal surgery, disease severity, and others. And as the diaphragm dysfunction risk score considered to its analysis these predisposing factors, it could help to identify earlier the patients with a risk of development of diaphragm dysfunction. And it could help the healthcare professionals to start earlier the rehabilitation. The present study has some limitations. First, a small sample size was assessed. However, the sample size calculation was done a priori the start of the study. The diaphragm thickening fraction was assessed only from 12 patients from the study. We did not assess mechanically ventilated patients, initially with the intention to avoid positive pressure influence in the respiratory muscles mechanics. And lastly, the diaphragm dysfunction risk score was not prospectively validated. Contributions to clinical practice. Our results bring important contributions to clinical practice by demonstrating that abdominal wall muscular support increases inspiratory muscles capacity, increases muscles capacity, so that the abdominal wall muscles have an important action during inspiration, not only during expiration. Furthermore, our study highlights that breathing patterns which emphasize the abdominal wall outward during inspiration, as the breathing pattern used during the breathing exercise, the diaphragmatic breathing exercise, are less efficient in promoting and improve in the inspiratory muscles capacity. The ability of diagnosing diaphragm motion dysfunction combined with the evidence of lung aeration loss should allow the health professionals to start an early diaphragm and respiratory muscles rehabilitation, especially in those patients with a higher risk of development of diaphragm dysfunction. And finally, it's important to highlight that the belt was used only as a methodological tool to simulate the usual abdominal muscular support. And it should be used and be useful in situations where it is not possible to promote an active muscular recruitment, as in tetraplegic or deeply sedated patients. So we can conclude that a breathing pattern with abdominal support has a significant contribution to the inspiratory pump action, promoting a higher increase in the maximum inspiratory pressure, diaphragm excursion, and diaphragm thickening fraction when compared to a pattern without abdominal support. Additionally, lung aeration loss, diaphragm motion dysfunction, and inspiratory muscles weakness are common complications in critically ill patients and tightly related. And finally, a diaphragm dysfunction risks for higher or equal to, based on the presence of sepsis, abdominal surgery, treatment by corticosteroids, disease severity represented by the SAPS-3 score higher or equal 40, malnutrition, and age seems to be a good predictor for deep breathing diaphragm dysfunction. Those are the references used in this research. Thank you for your attention.
Okay, thank you, Carol, for your presentation. Now we are going to start the discussion, and I would like to invite Professor Jean-Jacques Ruby. Professor Ruby is a professor from Sorbonne Faculty of Medicine at Paris, and he is the head of research in the ICU of l'Hôpital Saint-Pitié-Salpêtrière at Paris. Please, Professor Ruby, be comfortable. You can start your discussion with Carol, and both of you are free to choose the strategy that you want.
Thank you, Clarisse. First of all, it's a pleasure to be with you this morning. The presentation of Caroline was clear, well illustrated, and well presented. It was easy to follow, and Caroline, you should be congratulated for that.
Thank you, Professor.
Your study is a kind of a pathophysiological study with a potential clinical implication. So my first question is, you found a relationship, a significant relationship between lung aeration loss and diaphragmatic dysfunction. No, it can be the cause. The diaphragmatic dysfunction can be the cause or the consequence of the aeration loss. What is your feeling? Do you think that the aeration loss was caused by the diaphragmatic dysfunction, or that the aeration loss was a consequence of, or the aeration loss was the cause of diaphragmatic dysfunction?
It's a good question, Professor. So we have assessed only patients without mechanical ventilation, and only 4 patients included at the study have previously received mechanical ventilation. So our population was formed mostly by patients, not so complicated patients. And I think that it's possible that the inactivity, the position at the bedside of the patients can impair the respiratory muscles mechanics and contribute to this lung aeration loss, which was mostly observed in the lung-dependent regions. So I think the impairment in the breathing biomechanics could cause the lung aeration loss in this profile of patients that we assessed.
Okay, you know, one possibility to demonstrate this would be to correlate your diaphragmatic dysfunction score with the lung aeration score. Your diaphragmatic dysfunction score is based on clinical criteria and past history of your patients. So did you try to make this correlation? In other words, where the most at risk, according to the diaphragmatic dysfunction score, were those who had the greatest lung ultrasound score? Did you try to make the correlation?
Correlation between the diaphragmatic
yes,
score
and the lung ultrasound score.
No, we did not try to perform this correlation analysis, but it could be an interesting analysis.
Yes, because maybe if you find a correlation between both scores, so it would support your feeling that the diaphragmatic dysfunction is the cause of lung aeration loss.
Yes, it's true.
Okay, another question. In your patients, many of them had been operated from surgical procedures. So I have one question. If you have an abdominal incision with a dressing, do you think it's possible to use your abdominal belt without injuring the recent incision? In other words, if I get a patient from the OR that has been extubated, can I install the belt immediately without damage on the abdominal incision?
Yes, it is possible because the tension applied to the belt with the belt to the abdominal circumference was a low tension, just to offer a support to the abdominal wall, as the same support that we can do usually with the tonic activation of the abdominal wall. So it was a slight increase in the intra-abdominal pressure, so that it was not possible to do a damage, to damage the abdominal incisions. We didn't have any problem with this.
On the contrary, it would protect the
Yes,
incision.
Professor Clarice is saying something important here, that we observed the contrary. Sometimes the belt protected and facilitates the breathing biomechanics in those patients with abdominal incisions.
Would you use a 10 millimeter abdominal pressure with the belt? Because when the patient is coming back from abdominal surgery, the abdominal pressure is already increased. This is the same with a patient undergoing laparoscopic abdominal surgery. So would you use a 10 millimeter of mercury abdominal pressure or a less pressure?
Oh, 10 millimeters of mercury are possible to use because the support is very, very, very slight. Is not a huge tension. And we have based this tension selection of 10 millimeters of mercury of tension applied with the abdominal belt. We extracted this information from research which evaluate the normal intra-abdominal pressure during a semi-recumbent position. Maybe we could put this information in the study protocol methods.
If all of you agree, the examiners agree, I would like to give a contribution in this special question, because in my opinion, I wouldn't do that if because in this case, you have already higher abdominal, yeah, intra-abdominal pressure. So I would a little less tension in the abdominal support. I think that it's not the.
In this kind of patient with an increased intra-abdominal pressure with a risk of compartmental syndromes and
exactly.
And patients with this gravity, maybe the belt would be not indicated, but the patients included in our research did not have this kind of complication. So it was it was not a problem to put the belt with a tension of 10 millimeters of mercury. But if the patient has an increased intra-abdominal pressure, it would be.
Okay, I have two last questions. The first one is, did you try the abdominal belt? Or did you compare the effect of the abdominal belt in patients with and without diaphragmatic dysfunction? You know, my question is, in patients with diaphragmatic dysfunction, is the abdominal belt more or less effective than in patients without diaphragmatic dysfunction?
In our research, we did not divide the patients into groups for this analysis to observe if the abdominal belt in patients with less diaphragm motion or less slow with diaphragm dysfunction, if they have a higher improvement in the inspiratory muscles capacity. We did not access this information, but it could be possible that when a patient has a diaphragm dysfunction, the belt, the increase in intra-abdominal pressure facilitates more the diaphragmatic dispersion and the diaphragm thickening fraction. Another research, which is part of this bigger research, were done with health patients, were performed with health patients, and they have demonstrated an improvement in inspiratory muscles capacity. But with ICU patients, this improvement seems to be higher. We cannot make a comparative analysis between these groups because they are not paired. But it seems that patients with a diaphragm dysfunction could be a higher improvement in inspiratory muscles capacity. It's quite similar with tetraplegic patients. They don't have the abdominal support naturally, so sometimes they can have an less inspiratory muscles capacity, and it increases when we offer an abdominal support.
Okay, if I may comment, in quadriplegic patients, the diaphragm is normal, even overtrained, because of the abolition of thoracic, inspiratory, and expiratory muscles. So it's not the same in critically ill patients who may have a diaphragm atrophy, you know, and who may have a diaphragm weakness. Okay, so my last question. Of course, the major limitation of your study is the small number of patients. Do you have any plan to go on to include more patients, even non-critical ill patient, you know, like patients undergoing major abdominal surgery, but not admitted to ICU, I think it would be extremely interested. Are you going to go on and to collect more data that could also validate your diaphragmatic dysfunction score?
I think this research should go on, should continue to reach a significantly possibility of generalization of the data. We have performed a sample size calculation before starting this research, so that it was needed 30 patients to perform the analysis, and initially we collected these 30 patients. But in fact, 30 patients are a small sample size, and if we could collect more patients, the research could reach more visibility. And in other populations, this abdominal support can also improve respiratory capacity. We did not assess COVID-19 patients, for example, but during the COVID-19 pandemic, we have used the belt to improve respiratory mechanics. And we could even see an improvement in parameters such as complacency and other parameters. I forgot it.
What do you mean?
Okay. Thank you very much for your nice presentation and your beautiful work. Merci beaucoup, Caroline.
Thanks, Professor Ruby, for all your help during this research conduction. Thanks a lot.
Okay. Are you done, Professor?
Yeah.
Thank you. Thank you very much, Professor Ruby. Now we would like to invite Professor Luiz Marcelo Malveição. Professor Malveição is a professor at the Faculty of Medicine here, our school here, and he's also a coordinator of surgical ICU in the Instituto Central das Clínicas. Could you please, Professor Malveição?
Thank you. Can you hear me all?
Yes.
Yes.
I have a first question, is that should we continue in English or should we go back to Portuguese? I would prefer to keep in English in order to keep Jean-Jacques in the discussion.
Yes, we can keep in English.
Okay. First of all, I'd like to thank you, the Department of Physiotherapy and Professor for the invitation to participate in this board to evaluate the thesis of Carolina. And the first thing I'd like to say is that it's very, very tough, very, very tough to present whatever is in a non-native idiom. It's very, very difficult. I had that experience in several times, and even with the time, it keeps being difficult. It's not easy. So this is a major accomplishment, and you and Professor Clarissa should be congratulated for this major effort to internationalize the post-graduation program from the physiotherapy department. And Carol, I'd like to discuss with you a few technical aspects of your thesis, and then a few philosophical questions that I would like to know how do you think about. And in order to start, I like to say that your presentation was really clear. Your slides are very clear. You spoke slowly, and this really improves the comprehension. And the only thing I had some difficulties was with the mask, because my connect here in the hall is very bad at the moment, and we have to use in order to understand what you're saying. So, starting now our discussion, I like to hear and talk about the role of therapy in the ICU.
Professor Luis Marcelo, could you repeat the question, because the connection was...
Okay. I'd like to think about the role of the therapy in the ICU within the context of a multidisciplinary ICU.
Where I think about the physiotherapists is...
What's the role of the physiotherapist? How do you see the process?
With the team. Oh, this is the most important thing in the intensive care unit world. The teamwork is very important, and the physical therapist has an important role, not only during the respiratory rehabilitation, but also in the motor capacity rehabilitation. So we are an important integrant part. We are important part of the team. So during this pandemic, we saw how we are an important part of the team. I think nobody do the works alone, and the physical therapist is an important member that, together with the physicians, the nurses, we can improve the patient's outcomes.
Perfect. For you to know, some 17 years ago, when I arrived here in the Central Institute, one thing I missed a lot was full-time physiotherapy in the ICU. And along with Professor Clarice, I remember when we started to have 24-hour physiotherapist in the ICU. I can tell, Carol, that this changed the outcomes of the ICU. We are able to discharge the patient much earlier than before, because we had a physiotherapist helping to resolve mainly the respiratory problems. Nowadays, we see the impact that the physiotherapy has on the recovery, but the adaptation and of the patient to a better physical condition. This is a great role played by the physiotherapist, and this is something that should never lost of sight. So, in order to discuss a little of your thesis is really nice. I have a few methodological questions you couldn't clarify to me. How did you select your sample size? Because to me, even though you did some calculation, is a small sample size. How didn't you look for a bigger sample size in order to have a higher significance of your results, a higher power? I don't know.
As we did not found any similar work or research in the scientific journals, we performed a small pilot study, and then we analyzed the sample size that were needed to perform this research. We used a pilot study with the same methodology of our main research, and we performed this analysis using the Power software.
I think that's important to mention which endpoint did you,
Yes, it's true.
and also how did you recruit the patients?
Yes. we used the diaphragm excursion as the main outcome to perform this calculation. And we selected the patients for this pilot study within the patient, as the patients that were admitted at the CU during the period pre-initiation, before the initiation of the major data assessment.
I understand what you're saying. You did a formal sample size calculation, but it seems to me that a bigger sample size would bring us more robust results.
Yes.
I think maybe more patients would give us more robust results. But a second question related to sample size is, I really understand that you calculated your sample size in order to answer the first research question, but we had a second research question and you use a different sample size. Why the sample sizes are not the same in the two research questions?
This is a good question, Professor. As you can see in the methods, we have to perform a lot of respiratory maneuvers to analyze the data. So during the breathing pattern 1, the patient has to perform 3 maneuvers for vital capacity collecting, 3 maneuvers for maximum respiratory pressure, 3 maneuvers to diaphragm excursion. So it was a big effort for the patients. So the first 24 patients, we could do this analysis, but we could do these assessments during the breathing pattern 1, because during the breathing pattern 1, we did not presented any orientation for the patients to perform a maximum respiratory effort, emphasizing the abdominal wall outward. So it was a data more natural, without any intervention. So we did not could continue this data collection along the research because it was quite invaluable.
I think that he's asking about the second research question.
Yes.
But I think that he's asking about the diaphragm thickness.
I think it was about the sample size of the second research question.
Yes, I couldn't hear Professor Clarice what she said because the communication scrambled a little, and no, it's I think it was the connection, was not the mic, and communication was scrambled. So Professor Clarice repeat what she said because I didn't get.
I was just trying to clarify for her the question because I think that she didn't understand perfectly your question about the first and the second research question because the total number of patients was different between the first and second question. Was it your question?
Yes, but she said something that she maybe the electrical current here in the hospitals.
Here at Faculdade too. I think Professor Luis Marcelo.
Carol, sorry, I think you can approximate the microphone. Yes.
Okay.
Because the sound is not clear for us.
Okay, now it's better, Carol.
Yeah, it's better.
I think Professor Luis Marcelo.
Eu vou escrever para ele. Sair e entrar.
Yes, I think it's better. I think his connection home.
Aqui teve uma queda de energia um pouco na minha casa também.
Eu tenho a impressão que foi geral, porque aqui também, no mesmo horário,
Caiu um pouquinho, verdade.
Uhum.
e no hospital, Luiz Marcelo também caiu, acho que deu um tilt.
Bom, a gente espera.
Okay.
Foi a fração de diafragma, a fração de espessura, que foi com menos paciente.
A segunda pergunta, nós não usamos os dados de 30, foram de 24. Foram os que inicialmente foram avaliados durante essa parte inicial, mas depois a gente fez aquela análise da metodologia.
Então, ficou corretinho a sua resposta. Luiz Marcelo.
Connection problems, Professor Ruby.
Yeah.
Technology is good,
Yes, I can see.
but sometimes it can do a
Yeah.
mess.
Is it very warm in São Paulo?
Yes, a lot.
Because I can see everything. Everybody's drinking, you know.
Yes, it's very hot, Professor. I think it's kind of about 30 degrees or
Okay. So here in Paris, outside, it's 2 or 1 degree.
Oh, that's nice.
It's winter.
quite different from here.
Yeah. So we lost Luis.
Yeah, we are just waiting a little bit.
Yeah. Caroline, when you were measuring the diaphragmatic parameter, you were doing that on both sides, right and left.
We performed the assessment at the right side of the bar.
Okay. Is it possible to do it on the left side too?
Is it possible? It is possible, but the ultrasound window from the left side, it's not so good because of the, how can I say pancreas?
Spoon?
Spleen?
Yeah.
Because of the spleen.
Ah.
But it is possible, but it's not so easy.
So there might be some cases where the left side is different from the right side. Let's take the example when the surgeon is taking off the gallbladder, okay? There is an immediate local impairment of the diaphragm that might not be seen on the left side. So maybe in the next studies, if you can do it also on the left side, it would be a guarantee to have the real diaphragm picture.
Yes, it's true, Professor. Most part of the most research uses only the right side.
Yeah. Ah, Luis is coming back.
Welcome back. Continua congelado.
Oh my God.
Can you hear me?
Yep.
Yes, yes,
Can you hear me?
yes.
Yep. Eu acho que nós estamos juntos. Não, ok.
Are you hearing us?
Oh, nice. I'm using my cell phone because the internet connection here in the hospital fell down. And I know how long it's going to take to be reestablished. So it's a technical gymnastic in order to go back to get back online.
Yes.
So, okay, I got the question on the sample size. I'm convinced it's really tough to make the patient do a lot of respiratory exercises during this such a small period of time. But let me ask you something also technical about your method. Is about the blinding.
Yes.
Did you use a single or double blinding?
Okay. The patients were not blinded because
Sure.
if the belt is with tension or without tension. It was not possible to blind the patient. But the researcher that performed the assessments were blind. A second research covered the part of the abdominal belt with a sheet so that it was not possible to identify if there was a tension applied or no. And only the window for the ultrasound assessments were available to the
And the statistician was also blind to the groups.
What?
The statistician was also blind to the analysis.
No.
Okay, so it was a single blind. It's okay. It's not a major problem, but you have to tell that only it was a single blind. But the last point I'd like to ask you about this methodological design of your study is about the randomization. Because I missed it. You told us that you randomized your patients, but you didn't disclose how did you make the randomization. Okay, so it was a randomization in blocks of different sizes. It was a simple randomization. It was in the paper envelopes that you put the randomization codes.
A simple randomization in paper envelopes. We performed I forgot the word for sorteio. We performed the randomization before the research started, and it was closed in envelopes so that only the researcher that prepared the patients for the assessments knew which assessments were done first.
Carol.
Oi.
Okay, it's okay, but you should write in the thesis what kind of randomization did you use. Okay, it's easier to understand your design because it's a small sample size. It's maybe you may have a learning bias if the patient understands how the things work, and then you can have biased results. So, and how but there's no major problems up to that. But one question you have to disclosure is how did you construct your diaphragmatic risk score? Because it's you that developed the score, okay? And even though I understand the idea behind the score, it's not a validated score, okay? So you should be clear that you develop this for this study because of this or that, okay? Because it's not a validated score, and this I don't understand if the weights of each variable you introduce in the score is correct. Maybe something is different from the other. Maybe the points are not good points, okay? So a second study you must do is the idea is really nice, is to validate your score, okay?
Yes. I think it's the next step, maybe. And we reconstructed the diaphragm dysfunction risk score based on the major risk factors that ICU patients could present during their ICU length of stay. And we considered some variables more that could impact more the diaphragm dysfunction, as for example, a major abdominal surgery with an incision more proximal to the diaphragm, more related to the diaphragm position. We scored this point a little higher in the diaphragm dysfunction risk score. But it's important to detail how the diaphragm dysfunction risk score was developed and finally validated it. It's an interesting idea, and it could be an instrument to allow the healthcare professionals to start the rehabilitation earlier in those patients who presented more risk.
Okay. No, it's a nice idea, but what I have to say is that I don't know personally. I don't know other scores that evaluate diaphragmatic dysfunction. I don't know Jean-Jacques. Jean-Jacques usually knows much more about this than me, but I don't know. I don't know these scores to evaluate diaphragmatic dysfunction, and this may be something that we could use in the rehabilitation, as you said, of patients undergoing mechanical ventilation, for example. Okay, so maybe if you find this thing, you can do that. If you find this other thing, you can do another thing. Okay, so maybe you can stratify the procedures you need to do with the patient with your score, but you should validate it before. I think it's a nice idea I never heard of before, and something very interesting for me. Okay, so let me ask you. You showed that your maneuver helps the patient to breathe easier. Okay, but it needs a kind of knowledge that's not usually taught to the physiotherapists. Okay, about the lung ultrasound or the thoracic ultrasound, better defining. So what do you think about the importance of teaching thoracic ultrasound, meaning diaphragmatic and lung ultrasound, to the physiotherapists in the ICU or whatever context?
I think lung and diaphragm ultrasound are really important tools to the physiotherapists, especially in the ICU environment. The patient changes its clinical condition many times during the day, so that it's impossible to perform an X-ray or other images evaluations many times per day during their ICU. And the ultrasound makes it possible to know how the patient is at that time. So it can improve our assessment too, better than auscultation, than X-ray, than tomography, computed tomography. And we can also evaluate the effects of our intervention. It is not largely used by physiotherapists, but it is increasing the use. And an important thing that you said is about the training, because ultrasound evaluation depends on the person that is performing the assessments. So the training is the most important thing when considering using the ultrasound.
You got to the point. Ultrasound is really important. The physiotherapist can assess all your interventions in real time. It does not need an X-ray in order to see what you have to see. For example, at Jean-Jacques ICU in Paris, they do not use, I don't know, routinely X-rays. They do lung ultrasounds for whatever needs. So, Carol, this is really important. We are all here enthusiasts of the use of lung ultrasound in the ICU. But how do you see the future? What are you going to do with this information? Are you going to discuss with Professora Clarice that the future is based on the lung ultrasound and all the physiotherapists must know? Is this?
I think the future is about the ultrasound because of the real-time images. We, as physical therapists, we work with movement, and the ultrasound allow us to visualize the body in movement. So there is a lot of possibilities that now we are not exploring using the ultrasound. And I think in the future, it could be more and more used by physical therapists. And maybe this knowledge should be included in the graduation schools. I think this would be the most important contribution.
Okay. This is really real nice to hear you talk about at the side of the heads of physiotherapists teaching in São Paulo University, along with Professora Carol Fu, that also is a professor of physiotherapy. And this is the direction to the future. But as we know, me and Professora Clarice and another guys are working with understanding how long it takes to learn physiotherapy, learn lung ultrasound by the physiotherapists. This is a project that's ongoing now, along with Professora Clarice, Catherine, but we're talking about lung ultrasound and about diaphragmatic ultrasound. How long it takes to learn?
Yes, we don't know how it takes to learn. We could do a research about it. Because
another question. So, and my final question, and I'm really satisfied with your answers, but my final question is, what are your next steps in order to keep going on your research career? Once you are going to be a doctor, and doctor is no more than a researcher. What are your next steps?
I always have this dream to participate in a doctorate graduation. I came to São Paulo with this objective, and now I'm in a step to conclude it. And someday I would like to be a professor, as you all. You all are inspirations for me, and I want to continue performing researches because I am a curious person, and I want to keep continue investigating and contributing to the physical therapist profession. I think we have to be able to put in numbers what we see in the patient's recovery. This is a gap in the physical therapy profession. So I think we must continue doing it, and I want to continue doing it. And maybe sometimes I could be a professor at FMUSP.
Sure, we are going to get there. Sure. Again, I'd like to thank you, Professora Clarice, and you, Carol, to the invitation to participate in your doctor evaluation board. And again, congratulate you for the beautiful presentation and nice thesis, and Professora Clarice for this real Herculean job to make everybody defend the thesis in English. Real nice. Again, congratulations. I hope to see your paper published bientôt, like the French used to say.
Thanks a lot, Professor Luis Marcelo. You have always been a great partner for physical therapy team from the Hospital das Clínicas, and you helped a lot in this research conduction. Most patients are collected in your ICU.
Comme le disent les Français, les doors sont grandes ouvertes pour la recherche.
Oui.
Okay. Thank you, Professor Luis Marcelo. Now I would like to invite Professor Carolina Fu. She is a PhD, a professor at our department. She teaches in exactly this matter of ICU treatment procedures. So it's very nice to have you here today. And also, I think that you were in her comprehension exam, wasn't it? I think so. Ela estava no exame de qualificação.
What is the same from the
Oh,
qualification?
Yeah.
Thank you, Professor Clarice. Do you hear me?
Yes. Yeah.
Thank you, Caroline and Professor Clarice, for the invitation to participate of this thesis. It's a great honor for me because I follow from the beginning of this research, and I follow Caroline in the hospital, né? And I want to say that it's really, you just really deserve this title, this PhD title, because of your competence, and you are a brilliant researcher. Okay, so do you hear me?
Cry like this.
And I agree with Luis Marcelo when he said that it's tough to present a thesis, to do a presentation in English. Our students be very stressed in the presentation, in a PhD presentation in Portuguese. So in English is more difficult. So I want to congratulate you because your presentation was excellent, clear and well illustrated. It was very good. I like it so. I love it. Okay, so I have some questions. A few questions because you had answered some questions that I have noted here, and Luis Marcelo and Professor Ruby had asked you previously. Okay, so about the shape of the thesis, I will not ask you, or because you have corrected them in the presentation. Okay, so I have some questions about some points. I will ask you now. So the characteristics of your patients, because the title of your study is you want to correlate the diaphragm dysfunctions with the ultrasound. Yes, ultrasound in critical ill patients. The characteristics of these patients, of your patients, for me, it's not critical ill patients. You can use this patient, you can use this your descriptions in wards, hospital ward patients. Okay, so I know that you intend to do this study in the ICU because it's your job, the main job is in the ICU. So in the manuscript, I I have this point about the characteristics of the patients, because I think I have you forget, I imagine that you forget to describe the main characteristics of these patients. I think that the main characteristic of an ICU patient is if he was received mechanical ventilation or not. And in your descriptions, you don't wrote it in your characterizations. I want you to tell me about this, because your Glasgow score is good. I know it, because you want to have patients with conscience, a good conscience. Yes, but they are not critical ill patients. They are patients they are good. They not because they were in the beginning of the stay in ICU, and if you want to use this study in poor patients, okay. If you want use this procedure in patients out of hospital, okay. So I think that is the problem in your title, perhaps. So I want you to tell me about this. Did you understand my question?
Yes, I could understand it. Maybe we should put on the title that the patients were in spontaneously breathing. This is the main characteristic of the sample that we assessed in the ICU, because the ICU is not only composed by mechanically ventilated patients. It's about 40% of the ICU patients are in mechanical ventilation. So the other patients are breathing spontaneously, and our intention was to exclude the positive pressure influence in the respiratory breathing biomechanics at this primary point from the research. So first, we want to know if the abdominal wall support can increase inspiratory muscles function. So after that, we can see if this effect is higher or equal in patients who is receiving mechanical ventilation. The sample is formed with critical illness patients, but is a part of critically ill patients that are not in mechanical ventilation. So it's specifically part of the sample of the ICU. So we can put it on the title that were formed with patients in spontaneous breathing.
Yeah. Another point is, but Luis Marcelo have argued about, is about the DDRS, the score about diaphragm dysfunction. You didn't describe how do you develop this score, and more important is the fact that this score is not validated. So I don't know if you can use it in your study. Okay, but it's a very interesting score, and I think that you can the group can do another research about it. Okay.
This idea
for me is a problem. Is the other point in your manuscript is this DDRS score.
This idea emerged with a discussion about the data with Professor Jean-Jacques Soubi. It was a great idea, and I think it could be prospectively validated in a larger sample size. I think it
Yes.
is an interesting score risk evaluation for the ICU patients.
Yeah, very good. The randomization, you answered this question, so I will not ask you again about this issue, okay? I liked very much your discussion because I like very much to study the diaphragm function. Professor Clarice know about it, and I liked your explanation about this, about the results of your study. And I think that your thesis is a very important, have many informations about the study of diaphragm, and the students will benefit, yes, with your study. I want to congratulate you both about this, okay? And I have a question, perhaps the last question. It's about our role in the ICU, okay? The main results in your study is the correlations with between the LUS and diaphragm dysfunctions. So the main message in your study is that the abdominal support is abdominal support is procedure that help us to do expansion in the lung with I want to say com mais como é que eu ia dizer? I forget the word. So, I want to ask you what the new, because in the we do it with the hands in the abdominal to do this procedure, this maneuver with the patients when I want to expand the lung. There is another procedure that the group suggests to do with these patients.
Oh yes, this is a great question, Carol, because it is the main information from this research, that we need to look at the respiratory muscles, the abdominal wall, not only to improve cough efficiency and speaking, but also to improve inspiratory muscles function. ICU patients not always have only diaphragm dysfunction, but they have that abdominal wall, a complacent abdominal wall without a tonic activation, inadequate tonic activation, which can impair diaphragm dysfunction. So sometimes it's not about the diaphragm, but the muscles that need to act synergically with the diaphragm. So we need to put in our clinical practice exercise that can improve this tonic capacity of the abdominal wall muscles with manual stimulus, For example, exercises stimulating the activation of the abdominal wall. When patients are deeply sedated, we can use another tools as the belt or electrical stimulation. So we need to look at the abdominal wall muscles, because sometimes it's not only the diaphragm. The other respiratory muscles have this imbalance that can contribute to a fake diaphragm dysfunction, if I can say like this.
Everybody knows that our role in the ICU is not care about the mechanical ventilation and the respiratory function. Now we have the earlier rehabilitation of the patients, and this is an important point that we have to do. So I know that the group principal, Professora Clarice, as a great researcher in the functional reeducation. And do you know that this type of procedure we can apply in, we can add in the earlier rehabilitation? Do you understand me?
Yes, you can add this kind of stimulus and exercise in the early rehabilitation. So we need to think about the abdominal wall muscles as we think about the quadriceps muscle, as we think about the diaphragm and other important muscles.
Because the size of the abdominal wall is the principal point in the functional reeducation.
Yes, we need to use the abdominal wall to maintain a trunk control, to be able to sit at the bedside, to standing. So the abdominal wall is involved in breathing and motor functions.
Yeah, very good. Caroline, that's all. For me, I'm very satisfied. I'm happy with your with this work. I want to congratulate you and Professor Clarice. This study is a very important and relevant study, and I think that that these messages in the study is a main is very important to introduce the functional reeducation in the ICU, role of the physiotherapists. I think that, and not in only in ICU, but in the respiratory physiotherapy role. I think that. So I want to congratulate you for this study, and it's a great honor to participate of this thesis. Thank you.
Thank you too, Carol. You are an inspiration for me too, and you have accompanied this research, and I am very honored to have you all here with me as part of my board members in my PhD.
I have a last question for you. What's the next step for the group? Because I imagine that this study is a pilot, only a pilot. Your sample is.
So, if you allow me, I would like to to talk about it in my
Okay. Okay.
So that's all. Okay. Thank you very much, Professor Carolina, for your discussion, your questions, your comments. Always great support for us. So I would like to say a couple of words about this experience and about this this presentation that we have today. Two things, especially. One about my student, and the other about the project, and one more. The other one, the last one about the future. Okay. About the project, this issue is bothering my mind for maybe 2 decades. And it started when I was looking for my issue for my PhD thesis. My supervisor was my supervisor was a surgeon, general surgeon, and he had a special interest in abdominal wall, in the integrity of abdominal wall. And he was always pushing me to find the meaning of abdominal wall for physiotherapists. And in that moment, in that occasion, for me was, I couldn't find any meaningful subject involving abdominal wall. I was a very young physiotherapist at that time, with no experience. And for me, physiotherapy, physical therapy was much more about bringing back the patient to walk and to do their things and to do their daily activities, and that's all. And that's all the physiotherapist for me in my mind at that occasion. But this issue was never left my mind. And a couple of years after that, I started to understand the relationship between abdominal wall, diaphragm, and trunk, etc., etc., etc. And then looking at the physical therapy procedure of diaphragmatic exercise, asking asking the patient to breathe with that outward displacement of abdomen. And at that time, I was studying a lot of biomechanics. That was my program in the undergraduate student. And then I started to see, and I realized that was not feeling, that was not connecting. Something was wrong in that manner of breathing with outward displacement of the abdomen. That was not helping the support for diaphragm function at all. And then I started to fight about it and fight about this idea. But that time it was difficult for me to find a very nice tool to prove that exercise was wrong. That idea that for the maximum effect of maximum function of diaphragm, we had to expand the volume of abdomen. This idea was wrong, this idea is wrong, and a lot of physiotherapists teach exactly like this and do exactly like this in ICU and in ward and with athletes and everybody. So that thing was bothering my mind has been bothering me for a couple of years. And I am not sure how long for. And we tried a lot of things to find a perfect tool to prove that this was wrong, that abdominal wall could not be outward displaced for respiratory exercise. That was not helping the diaphragm. And then one day I was presented to ultrasound. That day was kind of, okay, that was my day. That was my answer. I was looking for this tool for many years. And then I would like to thanks, to show my gratitude for Professor Luis Marcel, Professor Ruby, and then the group over there in that ICU in which I was presented this to the ICU. And this was the main point to be here today, presenting this thesis. And I think that was the main thing happening in these 2 decades, maybe, because I was looking for that for along 2 decades, more or less. This is the background of this research. I was so bothered about this situation. And recently, I also was studying the central motor control of breathing. And then once more, I was bothered by this idea that abdominal wall was an expiratory muscle. And that's it. No, it is not. It is not. Because in our central control, there is not this so tight difference between what is inspiratory and what control expiratory muscle. In the central control, the function is much more flexible than we thought previously. And this was reinforcing me that our thesis is strong now, and we can go on with that. And then about the student, when Carol was talking to me about a good issue for project question, and then I presented to her this idea, so she caught the idea immediately and start working on that so hardly, so effortfully than the result we have today. She is brave. She is smart. And then I think that we add in this recipe a good research question and a good student. And nowadays we have this extraordinary response and this extraordinary contribution for the science and for the practicing of physical therapy, in my opinion. And about the future, I think that we have some strong directions, and I wrote down here a couple of things about the future. And it's not like a sequence, but it's kind of points that I wrote down. Time for the conquer of ability to be trained for ultrasound. I think that this is a good thing to look for, and it's not too easy to do. This demands a lot of work and demands something that it's not easy for us because we are right now short-handed, and then it's not too easy to perform this research, but I'll see what we're going to do. I'll see that what is possible. The other thing is about this diaphragm risk score. I remember in the comprehensive exam, Professor Luis Marcelo asked so emphatically to keep going with this score, and we didn't yet, but we will do. And then I would like to talk about it in the next days about this subject. I think that the massive teaching, massive practicing of the tools of ultrasound is important too. We have at least one or two projects in this direction. Maybe it's time to give a direction with a timetable and things like this. And the most important, the central meaning of this project is the synergic relationship between abdominal wall, and diaphragm. This is the most important point of this project, and the contribution for the science. And it's so important that now we are conducting another project about this relationship based on Carol results. We are stimulating simultaneously electrically the diaphragm and the abdominal wall, and this has brought so meaningful results, clinical results for the patients. And then we are applying this protocol for no. We are applying this protocol for exame medular. Yeah, for spinal cord injuries, for difficult weaning, mechanical ventilation weaning, and I think that this is strong research, much more developed research, and we have already published 2 case studies. We submit at CHEST, and it was accepted immediately without any correction, without any comments. It was right away published. And we are now conducting a clinical trial with this subject exactly. This project that I'm talking about is an idea bringing up these results from Carolina project, added with some more knowledge about how these muscles are controlled in nervous system. So I think that I have listed some ideas for the group that is already going on, and some ideas that we have as partners set a meeting in the next future to discuss how we can arrange and conduct all those ideas that was brought up in this meeting, in this discussion. So if all of you are fine with this, or maybe if you can have some words, some final words.
Me do this. This project was a huge challenge, and we've had a lot of issues related to equipment, and sometimes it was not possible to do the data assessments. And we have some issues related to research conductions here in Brazil that make it difficult to continue sometimes with clinical research. But this
equipment was broken for,
yes, the
I don't know,
equipment
yeah.
was broken, we were without equipment, so it makes the data assessment not so easy, but it is worth it, because this subject is one of the most interesting subjects for me. I love to study about the respiratory muscles mechanics, and I think this is an important point, a key point for physical therapists from the ICU, because the respiratory muscles are involved in breathing, but they are involved in motor control functions too. They are involved in the central stabilization to maintain the patient in standing position and sitting position. So it was very interesting to perform this research, and I am very happy today to can present this for you and for all of my friends and family who are watching me in the YouTube link. And I'm sorry about this, but this is a very special day for me. And I would like to ask permission for you to say a few words in Portuguese, so that all my family and friends could understand my words. Então, eu sou muito grata pela oportunidade de estar aqui hoje. Ainda não terminou, né? Vocês não fizeram a ata final. Mas, quando eu vim para São Paulo há 11 anos atrás, eu vim com esse sonho de me tornar um dia uma professora, de me desenvolver na área de pesquisa. E, durante os anos de condução dessa pesquisa, a professora Clarice me deu inúmeras oportunidades de aprendizado. Eu pude participar de eventos internacionais extremamente importantes na área de terapia intensiva. Eu pude conhecer profissionais extremamente competentes, pude trabalhar com o professor Jean-Jacques Rubi, com a professora Carol Fu, com o professor Luiz Marcelo. Então, foram anos de muito aprendizado e pelos quais eu sou extremamente grata. E para mim é um dia muito especial hoje de estar aqui apresentando. Queria que meus pais meu marido e minha família pudessem estar presente fisicamente, porque é um dia extremamente feliz para mim. Mas eles estão me assistindo em casa, seguros, que é melhor. Então, eu só tenho a agradecer hoje todo o aprendizado ao longo desses anos ao lado de vocês. Eu acho que eu tenho membros da banca que são extremamente próximos e que acompanharam toda a minha trajetória até aqui. Então, eu só tenho a agradecer a vocês, a minha família, a professora Clarice, que sempre me incentivou bastante, me colocou alguns desafios meio complicados, né? Tipo, vamos qualificar e defender em inglês, mas que foram grandes aprendizados. Então, eu só queria agradecer a todos vocês, agradecer a todos vocês, a professora Clarice, aos meus pais, meu marido, todos os amigos do HC, de fora do HC, minha família. Então, gratidão só pelo dia de hoje.
So,
Can I make a few comments?
yes, for sure.
Amém, professor.
Okay, Caroline, you did a wonderful job, really. With
I think the
no, I can tell you that Paris, the University Hospital of La Pitié-Salpêtrière is supporting you, has supported you, and will support you. You know, Clarice has defined a very nice project. I was really interesting to hear that. The future is coming. And let's say that lung ultrasound will tell you if what you're doing, mainly the abdominal contention, is effective. It's a tool. It's no more than a tool. It doesn't give in itself a solution. But the main point is coming from help the abdominal wall to improve respiratory muscle function. And we need to define at-risk patient, critically ill or not critically ill patients. You know, the main problem with age is sarcopenia. You know that. After the age of 40 years old, my God, we are all concerned. We start losing muscles. And this is the main problem. If we take some drugs like corticosteroids, if we have a neurological disease, if we are ventilated for a long time, you know, mechanical ventilation is associated with a progressive respiratory muscle weakness because you do not use them anymore during mechanical ventilation. So the weakness of muscles is there. So mechanical ventilation is responsive, is a cause of muscle weakness. So what you are pointing here, the relationship between the abdominal wall and the efficiency of respiratory muscle is a key point. And thanks to you, thanks to Clarice, she told us clearly that she was thinking about that at night when she was sleeping for years. And now it's coming and we will support you. Thank you for inviting me. And I hope to come back as soon as possible to your beautiful country, you know. And if you can come to Paris as soon as possible, please come. Carolina, it's also for you. If you have the opportunity to come to Paris, come and visit us. We will welcome you. Thank you, thank you. Muito obrigado.
Thank you, Professor.
I would like just to say two more things about my student. One is she was initially registered as a master's student, and then during her comprehensive exam, we asked for an upgrade for PhD student, and she got it. So this was the very, very first first thing showing her potential as a student, as a great student, and a great researcher. I forgot to mention that. And the other thing is, almost 2 years ago, I had proposed to her to go overseas to spend some time and to discuss her PhD with some experts abroad. And it was everything going on so nicely. And then we were surprised with the pandemic, and we had to step back of this plan. And then we postponed this plan for a post-PhD phase. That was the two things that I forgot to mention about my student, just to have an example of the student that I was talking about in my speech. I think that we are ready to go for the deliberation.
I think we need to call them